Hey, good people. This week we're going to be talking about social work as we see it fitting in with healthcare, rehabilitation, and mental health. So we're going to get started right at the beginning with social work and healthcare. When we talk about social work and healthcare, one of the things that we want to make sure that we don't miss out on is the issue of social workers working within the public health arena or the public health realm. When we talk about public health, it's very important that we understand that the issue of public health is not so much looking at what a medical diagnosis may be, but the purpose and the focus of public health is looking at things, looking at the medical problem from an epidemiological approach, which basically means that social workers together with medical professionals are looking at and trying to identify social problems that could impact specific health issues and different types of groups within our society. A while ago, I participated in working with the then Conemaugh Memorial Medical System, their public health department, and looking at prostate cancer in African American men, and the way that we went about gathering information and providing education. Because again, from a public health perspective, we're looking at gathering information and providing education. One of the ways that we did that was we partnered up with area churches and provided brief educational seminars, again, just on the topic of prostate cancer, excuse me, in African American men. So that's something that we have to look at and be mindful of when we're talking about public health. Definitely social work and public health go hand in hand. Just a little side note for those of you who are planning to go on for your bachelor's degree and your master's degree, the University of Pittsburgh has an awesome dual degree program with social work and a master's in public health, and also a dual degree program with your master's in social work and your law degree. So that's just a little side note, just a little plug for y'all today. But let me get back to the lecture at hand. When we're talking about social work and health systems, we want to make sure that we have an understanding of how we see social work played out with primary healthcare systems and also hospital-based healthcare systems. With primary-based or primary healthcare systems, we're talking about seeing people in the helping profession working in medical clinics, working with insurance companies, HMOs, and healthcare centers. And one of the things that is taking place with the patients, consumers in that are utilizing the services here is that there is definitely an improvement in the quality of life for the patients, but most importantly, they are being referred to specific resources that will assist them in some of the needs that they may have that could be impacting or influencing a medical diagnosis. And all of that leads to a decrease, most definitely, in the admission and readmission rates into medical facilities. Now, when we talk about a hospital-based social work is something that is a very interesting beast. This is something that I did for many, many, many years at Allegheny General Hospital. So hospital-based social work is all about working with a multidisciplinary team and getting an understanding of the patient's diagnosis upon their admission, their diagnosis, their treatment plan, and then for you, the social worker, your job is to look at the discharge plan for this patient. And when we talk about looking at the discharge plan, some of the things that we have to be mindful of is assisting patients with home health care, arranging things upon their discharge, but also looking at how do we help them in continuing on in a healthy lifestyle. So there may be some opportunities where social workers at a hospital base would be working with patients in regards to some legal issues, such as an advance directive. That would be your information, you, the patient's information on what you would want to have happen for you should you be unable to make decisions on your care. Living wills, power of attorney, all of that information is things that you, the social worker, would be doing in a hospital-based setting. The book gets into and gives us a little bit of information about social workers in very specific areas in hospitals, such as oncology social workers and emergency room social workers. I can tell you from my perspective in being on the crisis team, my primary unit was the intensive care unit for neurosurgery. However, being again on the crisis team, as I said before, I was responsible also to provide coverage as needed in the emergency room and on the trauma unit. So when we're talking about working in two very high stress areas, there's definitely some added work that comes along with what the hospital-based social worker does. Some of the things that the hospital-based social worker does, again, in working with an oncology and an emergency room, is definitely working again, like I said before, with your interdisciplinary or your multidisciplinary treatment team, making sure there is definitely an understanding of a diagnosis, and looking to work with the family as well as the patient, to try to give them, again, some encouragement, to empower them through the diagnosis. Also to look at how can we try to set things up and mitigate or expedite the services that this client, consumer, or patient may need. And that's not just, I'll say this, not just specifically to oncology and emergency, but that's throughout working within a hospital system as a social worker. Now, you may also find social workers in long-term care facilities. And in long-term care facilities, we're looking at what some folks may call, which makes me kind of cringe, nursing homes. But when we talk about long-term care facilities, these are facilities where your patient, client, consumer can no longer care for themselves, or be safe, I should say, and care for themselves independently and need that assistance. So long-term care facilities do include nursing homes, they include personal care homes, they include adult daycare settings, and also included in that, when we talk about long-term care facilities, those patients who are still able to be somewhat independent and still hesitant to leave their home, there is an option of having home health care come in and work with them. Your primary role as a social worker in all of these agencies or organizations is to assess what is going on for your patient, client, consumer, to look at what their needs are, to make the appropriate referrals. It is not to interfere with treatment, but it is also to provide some emotional support and some very basic short-term counseling for your client, consumer, patient in those areas. Social workers who work within the hospice setting. This, again, is a very different type of environment to work in, a very stressful environment to work in, because we're talking about working with people who are diagnosed with a terminal illness, and we're looking at folks who are at end of the life issues that they may be dealing with. So your primary goal here in being a social worker in a hospice setting is to provide that resource of comfort and empowerment, and to work with the family and the patient so that we have the necessary, first of all, the necessary treatment plans in place, the necessary equipment, and to have as little confusion as possible around what is going to be taking place for the patient and what the family's needs may be. So again, you're going to be looking at working as primarily as an advocate for your patient and also the family, because be mindful that the family is going to have some very specific issues that they're going to be dealing with and are going to need your assistance with. This also in a hospice setting is going to be your multidisciplinary or your interdisciplinary team approach, because you're going to be working with not only medical staff, but you're going to be working with nutrition, occupational therapy, which again is going to be looking at the different things that a patient is able to do on a daily basis. But in a hospice setting, again, we're looking at people who have received a diagnosis and a prognosis of maybe 6 to 9 months or less, and they're still in need of that medical treatment. When we talk about excuse me, still dealing with social work in the health system, and we look at social workers and genetics. Social workers and genetics, this is very, very interesting, because we're talking about working with people, but primarily from an educational perspective. This would almost be similar to your psychoeducational type of intervention, where you will be providing counseling, education, and crisis intervention. So there's a lot of things that we have to be mindful of when we're talking about working in the role of genetics. And our book goes, our book goes into great detail about that information. Now, the next part that we get into when we're talking about working with social work, not just in the health system, but in general, is social work and HIV or excuse me, HIV or AIDS patients with those diagnoses. The thing that we have to be mindful of with this diagnosis is confidentiality is the key. When we're working with people who have been diagnosed with HIV and or AIDS, there is a lot of issues, and I'm sure you're all aware, there's a stigma that comes along with this. There's a lot of issues that our client, consumer, or patient may be dealing with, and one of those big issues is going to be the issue of loss, the issue of loneliness, and how do I prepare for what possibly may be the inevitable. So you as the social worker, as the helping professional, you're going to be, again, providing a lot of education, not only to your client, consumer, or patient, but also within the community. You're also going to be working, again, with that multidisciplinary or that interdisciplinary team approach, which would be with your physician, with your home care nurse, if that is someone that is has been ordered, going to be working with nutritionists, all of that. When we talk about working with patients who have been diagnosed with HIV, excuse me, HIV and or AIDS, again, you're going to find yourself in a couple of different areas that you may be working within. It could be in a primary care area, such as a community-based clinic. It could be in a hospital. It could be in hospice. It could be in home care. So these are just some of the areas where you may find yourself working, but primarily your main topic or your main issue is going to be to address with your client, consumer, or patient the things that they're going to be focusing on. And like I said before, that's going to be the issues of loss and loneliness, and how do I prepare for the next steps of what's going to be taking place in my life. Now, as we move on throughout the chapter, we get to the section where we talk about disabilities, rehabilitation, so to speak. So when we're talking about disabilities, our book gets into a great explanation and definition of defining disabilities. And there is a chart that's in this chapter that I really encourage you all to look at, because it gives you some very good information on how we may be the type of disability and an example of it. But we're going to deal with two specific types of disabilities today. We're going to be talking about developmental disabilities and later onset disabilities. When we talk about developmental disabilities, these are things, of course, that we see throughout the early onset in a person's development. It may be physical impairment. It could be learning impairment. It could be communication. It could be behavior. So a lot of these things, when we, the social worker, are doing assessments, excuse me, one of the things that we want to make sure that we are looking at is what is our client, consumer, or patient able to do on a daily basis? What are some of their activities? Are their activities limited? What type of care do they need? What type of how is their communication? Now, of course, if we're talking about an infant or a child, we're going to be focusing mostly on the parents or the caretaker. But as this person gets older, then we have to learn to adjust our attention to that client, consumer, or patient. Now, the other type of disability that we're going to be looking at is the disability that occurs or that is a late onset. And the late onset disability, these are things where, again, we may see this initially in a hospital setting because maybe it's something that came about as a medical diagnosis, as an accident, a disease. Maybe this is something that comes along with age. Maybe it is something that took place on the job. We have a lot of military members that return from active duty with a diagnosis that is a later onset disability. So, and it could be, again, a closed head injury. It could be an amputation. So there's a lot of things that we have to look at and that we have to be mindful of when we're looking at working with folks in our later onset disability. We want to make sure excuse me, that the services that we provide are going to be specific to our target population, excuse me, and that we have a clear understanding about what the abilities are that our client, consumer, patient may have, and that we are strong advocates for what their needs will continue to be. On the same lines of talking about social work and disabilities, there are several pieces of legislation that we need to be mindful of. One of the main ones that I'm going to jump down to is our Americans with Disabilities Act of 1990. With that act, we have seen a lot of changes take place in access, I should say accessibility and availability of public services and entrances into buildings and things like that. The Americans with Disability Act of 1990 is one that definitely prohibits strongly the discrimination of anyone that may be living with a disability. We also, when we're looking at working with people with disabilities, we get into the field of education. Public Law 94-142 looks at the Individual with Disabilities Education Act. This act, the IDEA Act, is one that prohibits, or I should say, it encourages an inclusive educational setting for any child, any person through age 21 in a public educational facility. So there cannot be, again, discrimination against anyone with a disability from receiving that education. We're looking at building inclusivity within the classroom. The Developmental Disabilities Assistance and Bill of Rights of 2000. This specific legislation is one that we look at, or should say that has been established, looking at what are the community-based services for adults within our communities that are in need of services coming from a developmental disability area. So again, that's some of the legislation that I want to make sure that at least you're introduced to, but you got to be mindful of, especially if you are in the social work program and you move on into one of the courses, the social welfare course. We get into legislation a little bit more there. Now, when we're talking about social work and disabilities, actually, I want to go ahead a little bit on here, and I want to get to this section here where we talk about what our primary responsibility is as a social worker. When we are working with people that may have a label or a diagnosis as a disability, we have to know that part of our job is to create an empowering relationship with our client, consumer, or patient. That we get to this place where we help them to recognize that the work that we are doing with them on their behalf for them is to get them in a place where they begin to live a productive life and are able to function according to their comfort zone and what the rights and availability of things made to them. So when we're thinking about, actually, I'm gonna go back a little bit here, guys, I'm sorry. When we're looking at the services that are provided for people working or in need of services, I should say, that are diagnosed with a disability, whether it's developmental or later in life disability. We look at rehabilitation services, employment support services. We look at also specifically services for the family. When we're talking about services for the family unit, we want to make sure that not only are we working with the individual, but that we're also working with the family as well. When we talk about becoming the voice or the advocate for our client, consumer, or patient, that is one of our primary jobs as a helping professional, is that we are mindful that the things that we are doing when we are working on behalf of someone with a disability, it's not about the alphabet soup behind your name. It's not about how well things are going to look for you and how good you look, but it's all about what's in the best interest of our client, consumer, or patient. It's not about what's in the best interest of an agency or organization, but what is going to make things right for our client, consumer, or patient, that they can be able to move ahead and have a productive life. Now we get into the last part of this chapter where we talk about mental health. When we talk about the issue of mental health, this is where I need for you to just to kind of pay attention to how we see things from several disciplines coming together, from psychology, sociology, as well as counseling into social work. and anthropology, I should say. When we talk about it for a mental health or behavioral health issues from a micro level perspective, dealing with the person themselves, we're looking at how well are, first of all, have they accepted or are they accepting of a diagnosis that they may have received, and how well are they adjusting emotionally to living with a diagnosis or um, behavioral health issue. From a macro level perspective, we're looking at several systems that could be in place. When we're talking about the macro level system, we're looking at different programs, we're looking at prevention, we're looking at health and wellness, we're looking at intervention, looking at substance abuse, we're looking at a lot of things that may be at play that could impact someone's behavioral health. Now, one of the tools that we have available to us as helping professionals is that DSM-5. The DSM-5 is the Diagnostic and Statistical Manual of Mental Disorders. This is a manual that is published by the American Psychiatric Association. Excuse me. And so with this manual gives us some basic information. Now, I need to make this clear for you when we're talking about using the DSM. When you're using the DSM as at an associate degree level or a bachelor's degree level, you're using it for a very specific purpose. You're getting some diagnostic language so you can communicate across the board with your multidisciplinary team. You're getting billing codes for your insurance companies, and you're getting information that's going to help you identify what may be the best practice or the best treatment plan that I can create for my client, consumer, or patient. With access to a DSM-5 with an associate's degree or a bachelor's degree, you will not be able to provide a diagnosis. You cannot diagnose someone simply because you will not have the credentials to do so. So I want to make that clear across the board. You're going to be using the DSM-5 again as a resource book for language clarity, for billing services, but also for information and just for a guide in applying the right type of treatment or providing the right type of treatment or intervention for your client, consumer, or patient. Now, again, we're talking about behavioral health. We have some very specific theoretical perspectives that we can look at. And again, this is where we see the influence of several disciplines: psychology, sociology, anthropology, biology is also in here. So from a psychological theory, from that perspective, in the very beginning, I want to say this was probably, and I'll just say it's in the earlier chapters because I don't remember specifically which chapter it was. We went over and reviewed some of the psychological theories. So I want you to kind of take a flashback and look at the earlier chapters and look at the theories coming from your psychoanalytic perspective, behavioral, cognitive, and your humanistic perspective, and how well those deal with, again, working with our client, consumer, or patient. From our sociocultural perspective, this is where, again, we look at society as a whole. How is it influencing and how is it impacting a person's mental health or the behavioral health? Some of the issues that we have to look at and we got to be mindful of coming from a micro perspective is that labeling theory. The labeling theory coming from, oh golly, I just forgot his name. Not Emil Durkheim, Robert Merton, sorry. Coming from Robert Merton, when we talk about that labeling theory and what does that mean? The stigma of the label when we talk about behavioral health and mental health. From a biological perspective, again, we see this, we learned some of this from Gen Psych, and you will probably learn a lot of this when you take your biology course if you're in the social work degree program. We look at our neurotransmitters. How are things being transmitted within our brain? The serotonin, the dopamine, all of that stuff that we have to be mindful of. Again, so we have a clear understanding of how we are working with our client, consumer, or patient. One of the things we want to make sure that we don't overlook is this epigenetic study, when we're looking at not just the physical environment, but the social environment and the impact that that has when we're talking about mental health and and behavioral health treatment. When we talk about behavioral health treatment, we have to get into this place where we look at a little bit of the history of service delivery. And some of the history with service delivery and mental health was this whole idea of institutionalizing people who either received a mental health diagnosis, or maybe they had a developmental diagnosis, but they were institutionalized. But we are now in a position we see in our society where deinstitutionalization is very big. Deinstitutionalization is an effort to discharge people or remove people, to decrease the number of people that are in long-term care institutions. Hospitalization, our book refers to it, but it's basically an institution, and increase kind of getting them back into the community, and increase in community-based mental health services. Now, when we're talking about decreasing hospitalization, increasing community mental health services, we're looking at some of the causes that impact this. We're looking at the economy. How is our economy impacted when we're going through this issue of deinstitutionalization? How is it impacting the institution? How is it impacting, again, society as a whole? When we talk about deinstitutionalization, we have to look at some of the concerns that folks may have with assigning or reassigning, or moving people out of the institutions into the neighborhoods, or their their neighborhood, the neighborhood treatment homes that they may be living in. We also, some of the things we have to look at would include the changes in the psychotropic medication. There have been a lot of improvements over the years in the type of medication and the effect, that the medication may have. All of these things we have to take into consideration when we're looking at this whole concept of deinstitutionalization. Deinstitutionalization happens from federal, state, local public programs, and they all have the outcome base of having former patients who were institutionalized become residents in public areas, whether it be in a living home, oh golly, I just lost the word, I'm sorry, a safe living home, or it could be in a personal care home. But those homes are often function either by private agencies or private individuals. When we're talking about, still sticking with the whole concept of social work and mental health, and please excuse my dog for barking. I don't know why she felt like she had to say something there, but we're talking about mental health and social work. Some of the things that we have to be mindful of as we go through an educational program, that you, the helping professional, have to have some very specific knowledge in some of these areas. The areas that we see here, these bullet points right here that talk about, oh, I didn't mean to go forward, looking at the DSM-5 as an assessment tool. We have to be mindful of, specifically within our state and local area, our laws, our ethical responsibilities, be knowledgeable about our clients' rights. We have to make sure that we are knowledgeable about the procedures when we're especially looking at the whole concept of deinstitutionalization. What are some of the procedures that we look at when we think about people who are in need of some very specific help that may need crisis intervention? And not just with deinstitutionalization, I should say, but across the board with folks who are receiving services based on behavioral health or mental health. Now, along the same lines of working with people with behavioral health, this is where we get to the topic of substance use disorders. And we have to have an understanding when we talk about substance use disorders that within our DSM and substance use disorders, in our DSM, it is no longer referred to as substance dependence or an addiction. But we are moving towards person-first language in treatment facilities and when discussing substance use disorders. So we're no longer referring to addiction, substance abuse, but whether we're looking at person first language. Even though you may still see, you may still see in textbooks and in some professional journals, you may still see substance abuse or addiction. Again, the focus for the helping professional in that setting is person first language. In our area, we have a very, very talented team, a very talented organization that provides professional development for any agency or organization that addresses person first language as it pertains to substance use disorder. So again, that's the direction that we are moving in within our profession. When we talk about substance use disorder, we have to have this understanding that substance use disorder, the reason why it is under the section of mental health and behavioral health, is that we begin to look at this as a brain-based disease. Although some folks want to refer to this as it's a choice, studies have shown us, when we talk about the impact and the influence of the substances on the brain, and this impulse or this need to continue using. So again, we look at this as a brain-based disease. This, and let me say this also real quickly, good people. This section in our textbook is very, 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 very brief when we talk about chemical dependency. We have a great course. Some of you may be in it. Some of you may be interested in it. It is the Introduction to Chemical Dependency. And there's another course, Drugs and Society, that deals and delves very heavily into the idea of substance use disorder and the impact of substances on the brain's chemistry. Some of the things that we look at when we talk about substance use disorder, and so I'm going to go ahead, is we look at the type of treatment that's available for our patient, client, or consumer. We look at behavioral health settings. One of the things that we want to make sure that we're always mindful of when we're talking about behavioral health settings is that your job as the helping professional with an associate's degree, with a bachelor's degree, your primary job is going to be assessment. You're going to be doing a thorough assessment of your client, consumer, or patient. You're also going to be looking towards other people for their input as it pertains to the treatment and the goals for your client, consumer, or patient. So you may be in contact with the client's permission, of course, with family members, with coworkers, again, with the client's permission, as it pertains to how is it going to be beneficial for them in the treatment process. Your responsibility also with an associate's degree, with a bachelor's degree, would be to, you could possibly facilitate some types of group meetings. Not necessarily counseling per se, a therapeutic counseling, I should say, but it would be a group meeting where people would have the opportunity to talk about some things, and your primary goal is to facilitate that discussion, to kind of keep people on topic, not to let folks get too far out in left field, but let them stay on topic so that there is that there is a point of resolution at the end of the meeting. Your job is also to create a treatment plan for your client, consumer, or patient, a treatment plan that is attainable, not one that you think looks really good on paper, but one that is attainable for your client, consumer, or patient. When we talk about the treatment plans, this is where we get into that a lot of our facilities focus on and provide services with evidence-based treatment programs, that they look at, again, cognitive behavior, the motivation behind it, looking at the type of work that you, the helping professional, would do, whether it be participating with your client, consumer, or patient in role playing, and feedback to them about what you hear them saying, looking to them and helping them with again, just hearing what they have to say when you're talking with them. And when you're working with them, you're going to be doing a lot of motivational enhancement with them. Our book talks about Just briefly, reflective listening, affirmation, asking open-ended questions instead of closed questions. The whole purpose of this motivational enhancement, again, I apologize about my dog, people, but the whole purpose of this is to get the client and the opportunity to tell their story, but to tell their story with a purpose, that they hear what they're saying and they recognize the change that can be made. Now, being mindful of all of this client, consumer, or patient who is in substance use treatment or who's in recovery is not by themselves. This is where sometimes we got to pull in that family-based treatment. Again, you're facilitating that communication all around the family. How can we help the family and this client, consumer, and patient come to a place of reconciliation and moving on throughout the treatment process? Again, when we talk about the treatment with substance use disorders, we have some 12-step programs. 12-step recovery programs are very, very, very beneficial for the professional counselor or therapist. The reason being is because in this 12-step program, your client, consumer, or patient has the opportunity to reflect even further, deep down, into what are some of the underlying issues that may have brought them to this place of substance use. Not that they can't get there in a therapeutic setting, but when they're in a 12-step program, some of the benefits of that is that you're talking about issues that some of the folks who are in that program with you have also experienced. So there is a great big deal of empathy within your 12-step recovery programs that kind of encourages and empowers the people that participate in that so that they can kind of get to a place of resolution for themselves. Another type of treatment that we have for substance users would be drug courts. Now, our book refers to it as family drug courts because they're looking at, again, the systematic perspective, that macro perspective. If there was someone that is using drugs, all the systems that could be in play, especially if they have children. So you may have child welfare in place. You may have juvenile justice in place. You may have, again, adult probation in place. When we're talking about the drug courts or the family drug courts, one of the biggest things that you're going to be doing as a social worker is providing what our book refers to as wraparound services, trying to provide a seamless delivery of services, coordinating a seamless delivery of services for this client who is participating in drug court, that they are able to maintain their required participation so that they can get to a place where they are successful in treatment, they're successful in other areas, whether it is education, whether it is employment, whether it is housing. But again, coming from a macro perspective, that they begin to experience success all along the way, so that we're looking at decreasing incarceration time for people that may have drug offenses, and not treat them as criminals, but treat them so that there is healing in the process for them. And I hope that makes sense, good people. The last thing that we want to talk about when we're looking at substance use disorders, are the different types of prevention programs. We look at prevention programs that, again, they are going to be evidence-based. And with the evidence-based prevention programs, there's going to be some very specific risk factors that are going to be known, as well as protective factors that are going to be known. One of the things that we want to do when we're looking at prevention programs is highlight the protective factors while not ignoring the risk factors, but making sure that we get an understanding of them, because our goal is to look at how are we changing the cultural norms within a community when we're talking about substance use and substance abuse. Also, our goal when we talk about prevention programs is we're looking at how we're providing education to strengthen not only the individual, but the family. When we look at prevention programs, gone are the days where we have someone coming into a classroom and they say, see this, this is a piece of candy. Look at this, this is a drug. Make sure you don't mix the two up. but we want to make sure that we are providing prevention programs in a way that it encourages the participants to ask questions. It encourages the participants to identify risk areas for themselves so that they are aware of and that they're confident in their ability to refrain from the influence of substance use. So that is our chapter on health, rehabilitation, and mental health. And I hope that as you read through this chapter, again, I'm going to encourage you to kind of go back to earlier chapters and look at, again, the psychosocial or psychological perspectives, I should say, the theories that we learned about, and also make sure that you have an understanding of the various elements that are involved in substance use disorder. Again, we refrain from addiction or abuse, and we start to use person first language. All right, good people. So there you go, in a nutshell, everything that you need to know. Briefly, I should say, a brief introduction about health, rehabilitation, and mental health. If you have any questions, comments, or concerns, you can always contact me by email or my office phone. This week, there will also be an assignment. I believe there's an assignment on this chapter, as well as the chapter quiz in your discussion posts. So I bid you love, peace, and bacon grease, and you all have a great, great week.